It is a big surgery, and that's why we screen our patients so thoroughly, and we talk to them in clinic about what is involved with this surgery. But after the surgery, most patients will stay in the hospital between 7 and 10 days. We keep our patients at least 7 days generally to make sure that everything is healing. They do wake up with a tube in their nose to kind of drain fluid from their stomach and help things to heal. Occasionally they'll wake up with a tube in their side, in their chest to drain fluid, and a feeding tube in the abdomen. It's called a jejunostomy tube as a backup tube for tube feedings if they're not eating enough in the beginning. That will eventually be taken out in clinic. During that time, from day one, we want the patients to be walking. It is something that I like to tell the patients they're 50% of the team. We do the surgery and get them through that, and then we want them to do the work to get better. And that means they need to walk. So from day one, we get them up walking 4 times a day. We have them use an incentive spirometer. It's a device that helps encourage them to take deep breaths and breathe. And we actually have a protocol where we give the patients these devices before the surgery. They take it home with them. We tell them to walk 1 to 3 miles a day to use this device and learn how to use it before surgery, because once they have pain after the surgery, it's important to use that so they don't get a pneumonia. After 7 days, once the tubes come out, so usually 2, 3, 4 days after the surgery, we start taking some of these tubes out, and patients get more comfortable, their pain improves, and part of that pain control is having an epidural catheter, the same kind of pain control someone has when they're having a baby, and that catheter really helps tremendously with post-operative pain control. And once some of these tubes are coming out, they start having a little more by mouth. So they get to drink some liquids, start eating some soft foods. And by that 7th day after surgery, we test them. They'll do a barium swallow and watch the dye go down to make sure there's not a leak, make sure things go through okay. And if they do, that's when we start looking at getting them home. And a lot of that depends on their recovery and how they're walking, what support they have at home, and that's when we decide to discharge them home. If they need to, they can go to a rehab center first before going home if they need more help to get stronger. And once they get home, the general recovery is between 6 and 8 weeks. Everybody's different with pain, but generally people are walking. They can do things that are aerobic when they go home, meaning walking up and down the stairs. But we want them to avoid heavy lifting. Those kind of things take about 8 weeks to kind of recover from. The real advantage that University of Michigan offers for this surgery in particular is our experience with it. This surgery, like I said, has been around for a long time and was originally partially pioneered here about 40 years ago. It is a surgery that is not performed everywhere. And studies have shown that the experience that the center has and the surgeons have is important on the outcome. So if you're going to have this surgery, would you have it by someone that's done it once or twice a year, or would you want it by a center that's done it over 100 times a year? We've done this surgery over 3,000 times now. We do it about 120 to 140 times a year. I think that's an important thing to consider. It's also the variety of approaches that we have available. We don't just do it one way, but it is something that you can talk to your surgeon about different ways that it's approached, and a lot of that depends on what disease the patients have and what other surgeries they've had before or treatments they've had before. But the traditional approach is something that we've had a lot of experience with. And it's not just the surgeon, it's also the health center itself. I think when you look at esophageal cancer, when you go to a center that treats it all the time and that performs a surgery all the time, everybody knows this surgery better at a place that does that. So when you get an x-ray or a CT scan or a barium swallow, those radiologists, they know what they're looking at because they've seen it before. Whereas a center that maybe only does it a few times a year may not recognize those changes or those potential complications. So there are some long-term, there's some long-term changes. Why don't we talk about that first? So I think one thing that patients should know is that this is a big surgery. There are some changes after the surgery that they need to know about. One of those is the stomach is no longer in the belly. Their stomach would be up in the chest. So there are some differences in not eating right away and laying down because some things may come up now that the stomach is up in the chest. Also, patients afterwards shouldn't sleep flat at night. They usually sleep at an angle, so a 30 to 45 degree angle, so again, things don't come up and get in their lungs at night. Patients, the most common thing is that patients feel full faster. So when they eat, they usually eat small meals. So instead of eating 3 large meals a day, they'll eat 6 small meals a day. There are some adjustments to make. But generally, patients are eating regular food, and those are adjustments that they make over time. What was the question you asked?
About long-term support.
Long-term support. So I think another advantage here at University of Michigan is the long-term support that we have available here. This surgery has been performed, over 3,000 times here, and we have a large support group. And it's amazing to see all these patients that have had the surgery and that get together. They actually meet sometimes every month or every other month. They'll either meet here in the hospital or sometimes out in a restaurant and get together. And the idea is for them to be able to talk to each other and support each other with their experiences. We do the surgery, but none of us have ever had the surgery ourselves. So these patients provide a very different perspective, and I think it's a very valuable one. We encourage our patients to do that. We have a website that they can go to, a CD that they can watch, or a DVD they can watch. But there's nothing that replaces talking to these patients and asking them, well, how is your life now? How have things changed for you? Would you recommend going through the surgery? I think those are valuable resources that we have.